Welcome to Make Visible, the podcast shining a light on complex chronic illness. I am your host, Emily Kate Stevens, and I've been living with an energy-limiting condition since 2020. Here, I will speak to the world's leading experts to bring you the latest science, research and insights into invisible illnesses, including ME/CFS, EDS, fibromyalgia, POTS, long COVID, and more. Welcome. Well, it has taken a while and quite some effort, but a new study looking at monoclonal antibodies for the treatment of long COVID is finally underway. And I had the pleasure of discussing it along with her decades of research into ME/CFS and other complex conditions with Dr. Nancy Klimas at the Institute for Neuro-Immune Medicine at Nova Southeastern University. Along with the deep investigative science that they undertake, we discuss existing ways to manage and treat patients, helping move the body back to homeostasis. What an absolute pleasure to be in the same room as this inspirational doctor, scientist, researcher, and thought leader. And I hope that you enjoy this interview as much as I enjoyed speaking with her. Dr. Klimas, I am very excited to be here in person. What we're trying to do at Make Visible is try and bring some of the research that people like you have been doing for decades into illnesses that have not got necessarily that much attention in terms of the actual global attention, and pull those strands together. So I came to this from having long COVID, but what has become so apparent to me is that emphasis on long COVID and the funding that has gone into long COVID has enabled us to actually start looking and start piecing together pieces in conditions like ME/CFS, which has been much underrepresented historically. Not underrepresented by people like you or Lucinda Bateman or these people that I have spoken to who have been working extensively and tirelessly for decades. Out there in the world, it has been underrepresented. Your focus is research and clinical efforts.
Yes, we do.
Into multi-symptom disorders. Is that how you would describe it?
I never liked the word multi-symptom disorders. No. But no, what we have going here is really exciting. We have a group of scientists and a group of clinicians sort of in a mind meld. It's pretty cool, doing translational research. So we have this amazing computational modeling team and biomarker discovery group and in vitro testing and all the laboratory bells and whistles, some really exciting stuff going on in the lab that leads to these kind of models for the complexity of these illnesses that give us new ways to think about it, but also to potentially treat it. So on the science side, we have all this preclinical work that's incredible. I mean, it's just like, wow. And it's all got to do not just with all the skill set of these people, but the fact that they're working together, talking to each other, communicating, improving the way we as a group are even able to conceptualize these illnesses. But then what we have in the clinic, or the clinical team, is the ability to translate that into clinical trials, which is nice. We also have a really outstanding clinical team doing treatment. And they inform us, as our patients inform us every single day, on things that we might not have conceptualized using all that fancy science. We were sometimes just listening to people and hearing what's going on with them is the way you find your direction and discover important things.
And as the director here, do you bridge actually each of those of the team?
I'm a very odd person because I have a pretty strong laboratory science background. I'm not a computational scientist at all. I have to go look up their words and then come back to the meeting later and go, okay, now I get it. But I'm good with the biomarker piece. But I'm also a doctor, a physician that takes care of patients, and I'm an immunologist. So I've been taking care of them through the lens of immunology for quite some time.
How recent is it to have that computational piece as part of the work that you're doing? You're talking previously about bench research that you're doing, but this must have revolutionized the speed.
You were speaking about Suzanne Vernon before we started talking. When Suzanne was at the CDC, she organized this amazing meeting with her colleagues at the CDC that put clinicians, scientists, and computational scientists together at a table and created a competition between 4 or 5 groups to try to model ME/CFS. And they handed them this big data set that the CDC had. So I was on one of these teams. And that's how I came to know about the strength of computational biology. Gordon Broderick was on my team, and we had designs on napkins sketched out in the evening of what we'd like to do. And it turned out to be a very great way to start down that path. So,
wow. So that's, what was that, 2005? Was she there?
Yeah, easily that.
Yeah.
And then I moved to Nova Southeastern University when they offered us the opportunity to develop our own institute.
And so you got that decision then to bring in all of those elements.
Came with the whole thing, the whole shebang. That was our vision when we came here, was that we would have a team that could move from the lab to models to patient care.
Wow.
Yeah.
I look at your website and see how often it has to be updated with your latest areas.
It's probably out of date again. But we've been doing a pretty good job of trying anyway.
So why don't we start with your latest projects that you're working on? You and I did actually speak a year or so ago about some work that you had been doing into monoclonal antibodies, and it was just off the back of
Dr. what a ride this has been since then.
So what happened is you were looking at potentially doing a trial into monoclonal antibodies, but tell me what happened.
So what happened, we got funded, which is amazing, to do that in January of last year, so a little more than a year ago. And the longest shelf life product at the time would have expired in July. So I tried to race the July expiration date with the things you need to submit an FDA IND.
Yeah.
It's not a short or an easy process. I will say the FDA was very efficient, but the getting to the point of the application is hard. Anyway, one of the things you need for the application is the commitment of the company with a product that you can link your application to their file at the FDA. Well, that never happened. There were, I think, 4 or 5 companies, and we went through them, knocked at the door, used powerful people to knock at the door from other directions. It just didn't work. We couldn't get them to work. But about that time, a British company, AstraZeneca, had created a second-generation product to protect people against COVID that were medically vulnerable.
Yeah.
And that product was in trial, but not approved yet, at the time when we found each other last summer, which was very good timing, with a lot of help from some amazing people to put us together and all the right people that could make decisions in the room. And AstraZeneca committed to providing us with product for this trial.
And tell me what that trial is, or is looking at, or is looking to address.
And there's so much more data since you and I talked before, because now it's even more exciting. So the idea is that some people, maybe not all of them, but some, what do you mean by some? Maybe 40% have this circulating spike protein from COVID long after they've had COVID.
And are we talking about people who have long COVID,
Yes.
or is that people in general?
Long COVID people.
So it's not 40% of the population, it's 40% of those
it's
with long
definitely
COVID.
not in the people that are well.
Okay.
So
which is a good point, because some people...
Because there is a signature that chases recovered people.
Yeah.
Look at the proteome studies. They're saying that every one of us that had COVID has a signature you can see years later.
Yeah.
So that's true, but it's not spike protein, because spike protein is actually is a piece of the virus, right? It's a chunk of the virus that's on the outside. It's the thing that binds on your receptors in your blood vessels to what's something called the ACE2 receptor, the binding site for this virus. It's actually in a lot of other tissues too, but on the blood vessels, it's particularly troublesome because starting an inflammatory reaction in the blood vessels going to give you trouble. And as you know, the people with long COVID have trouble that sounds like their blood vessel walls are part of the problem. They have microclots, perfusion problems. The work of Dr. Vust, him from the Netherlands, with the muscle biopsy, pre-post exercise that showed, ischemia and lack of perfusion in long COVID after an exercise challenge. These are all really important features of a illness that's affecting the capillaries, the tiniest blood vessels, and not letting the blood get through. So on one hand, you got this pathophysiology that makes you think, man, something's really messing up the blood supply here. Why can't the microvasculature open up and let the blood come through? And then on the other hand, you've got this data now supporting that there's this thing that binds to blood vessel walls that calls the immune system over and creates inflammatory reactions, which is the first step of clotting. So the microclots could be coming from that. So it just all starts tying together, right? Yeah. And you're going, oh, okay. And then there was some studies out of Japan that biopsied organs when people were having surgery for this or that. They did like liver and kidney biopsies, that kind of thing, and found more evidence that COVID was in the solid tissues than it was even in the blood vessels. So their numbers ranged up to, I'm just pulling this out of the air, I don't remember exactly, but it was really high, 60, 70% of the tissues that they biopsied. So there's this evidence that the virus is persisting, or the spike protein is persisting without the whole virus attached.
Yeah, I've heard you talking about this before.
It's a really important concept because when you have a bug, a bacteria, a virus, whatever, it can actually lend the code for something to other cells and leave that behind. And the cells can then start manufacturing things. Like HIV can make GP120 antigen, the little piece of the cell wall that binds to the T cells, in huge quantities compared to the amount of actual HIV that's circulating. So,
and is that what's causing the problem in something like this?
Yeah, well, in HIV, it causes a different problem. But in this one, you've got this protein that can be measured that is really a big problem. It itself, all by itself, can cause, reasonably, you could understand that having something that calls the immune system over to the ACE2 receptor is going to result in some serious stuff. That's the concept, the theory behind it. In the year since you and I talked, the data to support that is very, very much stronger. Dr. Ware at Harvard's lab has got this ultra-sensitive assay. He'll be a part of this study. And he's published some papers now with big numbers of subjects, not a handful, that are pretty compelling. So that's the argument behind why would you want to mop up spike protein?
That's what the AstraZeneca drug is. That's the target. It comes in and swipes the spike protein.
Monoclonal antibody, right? So it can, if there's a living virus that's replicating, it should grab it and bring the immune system over to kill it. But if it's just bits and pieces of spike protein, it should still suck that up into an immune complex and remove it. And the liver removes immune complexes in a single pass. So if you just sort of like a sponge, pop it up, and then these cells in your liver called the Kupffer cells.
Sounds like you're just literally, giving it a bit of a clean out.
Yeah, it's just kind of scrub it out. And the other advantage of this AstraZeneca product is that it lasts 6 months after infusion. So you only need one shot for 6 months, which is the length of our study. So we'll be able to know if, with some of the other products, they just didn't last very long. And you might have had to go back and get repeated injections. But this one, you have like 6 months of coverage. And then we'll follow another 6 months to see whether that was good enough or if it broke through.
And how many people will you...
100 people are going to be in the study.
Okay.
So it's 50 placebo, 50 drug. And then at the end of 6 months, anyone who has symptoms can get open label drug. So there's the opportunity for anyone in the study to actually get treated without being entirely on placebo the whole time.
Okay. And you said that they have trialed this, but that's trialing it in active COVID. Is that right? That when you said AstraZeneca have been looking at it.
No, actually, the way this drug is to prevent COVID, right?
Okay.
So you give it to people with immune system.
That's right.
And you try to prevent COVID.
Okay.
They had a very nice, more than 400 people in that trial and went on for 6 months. It's on their webpage. You can read it. It was protective. It was as protective as the first version of Evishield, which was released, as you know, a few years back.
Yeah.
Oh, and the other good news about this product is that it covers all the old variants, alpha, beta, delta.
And right up to current?
Right up to, not the current, up to the time when they made it. Because these variants change. Like tomorrow, you've got a new variant. You don't know until you test it if it's okay. But it's definitely good for the variants of up about a year ago.
Okay.
So,
another thing that I noticed about this particular project is that you've got private investment, haven't you? And it's funded by the state.
It's a combination. It's really wonderful that there was so much enthusiasm for this project at the state level, and Dr. Shepke in particular. He kept making these amazing introductions to people that could help. And there's a foundation called the Schmidt Family Foundation, which has got the Initiative for Long COVID, Silk Schmidt Initiative for Long COVID. They're doing global studies. They're very interested in doing global studies, doing studies that have matched funds from somewhere else so that they're not carrying the whole burden.
Are you finding that is a sort of model that you're having to rely on more and more? Is that private benefactor?
You're asking me today. Yes, the short answer.
Have
you been here in the United States the last months? Holy moly. But
that's going to have to be what more of your reliance is on that kind of thing.
We so need philanthropic support and private foundation support and little startup support, all the non-federal ways of finding support to take projects like this forward. But in this instance, this particular study, it's been a joy to work with the Schmidt Foundation because they not only funded it, they put their investigators together of all the things they fund and brainstorm together and network together and grow things that are even bigger than what the initial ideas were. So
that's amazing.
Really
and do people
neat.
Just do that because they want to be philanthropic, or are they doing it ultimately
I'm assuming that they are really philanthropic, but perhaps they have someone they care about that's got long COVID.
That's amazing.
They wouldn't have spun off this one. The Schmidt family is very generous in many ways, but actually they probably love our modeling work because they do a lot of supporting young technology and young people going into tech stuff. They have a lot of different ways that they use their wealth to do good in this world. So that's
wow.
Right.
We will have to talk about it once you've actually gone through that.
So where we stand for, and this is all good news, so compared to last year, it's slower than we hoped, but there was a process and it included an FDA IND. So we successfully have an FDA IND, which is a multi-month process. So yes, they required a fair number of changes to everything that we submitted to them. So we had to go back a bunch of times, but it's all good. We're good to go and we're ready to shoot out the gate. So we'll be recruiting and going.
So that is exciting news for people who have had long COVID for multiple years. But
it is exciting. I'm going to caution a little bit because I've been in this field of horribly ill people who haven't had cures in the horizon. And I'll say this, I think it's a very exciting study. And it could be a curative study, which is super, super exciting. I love that whole concept of curative. But I will say in chronic illness, like these illnesses are, there's a lot of things that make your life better that aren't necessarily the cure. And they're equally important. But when you go into a study that may be curative and you don't get cured, because it's all a gamble, it's a study, research, it's a hypothesis, we're testing it. I've seen people get so discouraged they're suicidal. Okay, so I'm always trying to warn people who are so
invested in
it that, I appreciate that. But I don't want you to be hopeless if this trick doesn't work, because we're working on lots of tricks. This is just a trick. And there'll be more tricks. And the science is so strong in long COVID. It's every day the amount of new knowledge that's coming out is growing, and it just gives us new and better ways to come at it. So the patients I know are impatient because they're sick right now, and science takes time.
Yeah.
But that Recover initiative, it's 15,000 plus people, longitudinal follow-up, digging deep into the biomarkers, coming up with models and doing, that's an extraordinary investment, but it's really hitting ground with, we're really getting some decent science coming out of that it's changing the way we think about this illness.
Really?
Yeah.
Have you found that from specifically from Recover? I know the Bateman Horn Center, and I think I was talking, was it Beth Unger or someone who I was talking to? There seem to be people who really, really rate the work that is coming out of Recover.
I think it's really great. And I went to the NIH meeting was last fall. They had a meeting of their investigators, and it was open to the public. And I didn't want to leave the room. Every single talk was like, oh man, when did they learn that? It's not out yet. It was really, really exciting.
Do you feel like, obviously horrendous for the people right now who have long COVID or any other of the conditions, but do you feel that this has actually just made leaps and bounds in terms of, I'm talking about the attention and the funding that has gone into long COVID?
The ME/CFS patients are still kind of the poor cousin, very much so, because even in the Recover Network, where we applied to be a site and we were turned down because we wanted to compare to ME/CFS, and they didn't want to do ME/CFS comparisons when they started the funding. Now they've liberalized a little bit, but they couldn't get. It was interesting because it's like 2022 or 3, whenever that was first happening, right? I swear to God, it was just like the beginning of acute COVID when people said, well, if we just study it, we'll fix it, it'll go away. And then how are you going to compare it to this long-term chronic illness? I'm like, because this is going to be a long-term chronic illness if we don't come up with big answers fast. So I think perhaps some people regret that they didn't grab the ME/CFS cohorts quite early.
Then.
Because they're an important comparator group to understand chronicity as well as acute changes, You have to fix people where they are in the course of their illness. If you have somebody that had COVID 6 months ago and they're still sick, they're going to be mostly inflammatory. There's going to be the microclotting. There's going to be a lot of systemic inflammation. And dysautonomia, the autonomic nervous system, is going to go kaput, all because of the very acute things that are happening in that window. But as you develop a chronicity, all these other systems that lean on each other lean into that illness. So there's going to be, the immune system becomes exhausted, immune exhaustion. It has immune senescence. It becomes less efficient. Viruses reactivate. Now you're dealing with other viruses that are reactivated, on and on and on. So if I have patients in a trial and they've been sick 6 months, or they've been sick 3 years, or they've been sick, in the ME/CFS case, 10, 20 years, those are important to understand the differences of how having an illness for a long time can. Where are your points of intervention? Did they change? And can you expect what you designed from these people with short-term illness to work on long-term illness? That's all great questions. They need to be answered,
Yeah. One of the areas that you have been looking into historically, but I think you've got a couple of studies that you are looking at right now, is the sex differences in ME/CFS, in Gulf War syndrome. So there's that idea in your mind, obviously, or your team's mind, that we need to look slightly differently at the way that is it the way that these things have developed differently between male and female, or is it just the therapeutic targets that we need to?
Again, we think of this whole thing as homeostatic networks being screwed up, so that when you're healthy, everything's in a balance. Your endocrine system, your immune system, it's all in this little balance. And if you listen to the modelers talk, they would talk about a well, like a little valley between two mountains. And if you got the flu, you'd get out of balance. You'd crawl up this mountain a little bit, but when you're better, boop, you drop back down into your healthy well, right? And the idea that a chronic homeostasis thing is going on, a chronic illness, is that you climb the mountain and you drop the ball down into the next well. And now you've got a chronic unwell person, but very stably sick. The things that are wrong are going to be the same things. What hormones are wrong, whatever. This is unwell but stable, and this is well and stable. And now I got to find a way to climb up the mountain and drop the ball back into the other well. That's sort of the theory behind our computational modeling group. And I think it makes good sense. And then you can deal with all the complexity. When you talk about gender differences, men and women are different in some very significant ways. Women are far more inflammatory. the immune system is more reactive. Women get all the autoimmune diseases far more frequently than men do, right? Men are swimming in this anti-inflammatory thing called testosterone that really quiets stuff down. So they have a biologic advantage on inflammation. So when we look at our models of these diseases, actually they model differently for men and women. They model differently for postmenopausal, perimenopausal, and premenopausal women. And actually the models predict different interventions for each of those stages of life.
Wow.
And it's because they're interactive, that the endocrine system is playing a role, and your estrogen and testosterone levels are in the model. And they drive a bunch of the imbalance that's involved in the illness.
Is it predominantly the hormone differences that you are looking at? No,
it's what the hormones do to everything else. You know, if it was just hormones, every guy would just start testosterone. And you have a low T syndrome. They have their TV ads here because they advertise drugs here. I don't know.
Yeah, we're not allowed to.
It's crazy. I remember when they made that. They advertised drugs, and there's this guy looking kind of wiped out and goes, I got low T.
And then he took testosterone.
And then he gets his testosterone. And I'm like playing golf and doing football again. So if it was just testosterone, we would have those bulky little football dudes running around. But it's not, because it's one of the easiest things to fix is hormone levels. So if all you do is fix that one thing, you don't make people better. But it puts the stage in place to be able to bump the other things that were completely out of balance and leaning into the wrong levels of all these hormones to stay out of balance. So in our models, we have to kind of fix the hormones and fix the immune system and fix the adrenal, the cortisol system.
It's very complex.
Yeah, it is. But it's cool, because if you don't think in a complex way with such a complex illness, I don't think we have a chance to make people better that have been ill for a long time.
So if you take those sort of three sections of the system, what therapeutics or interventions are you currently able to use that target each of those that enable returning to some kind of homeostasis or coming back into that well?
If you walked into clinic without the benefit of having evidence-based medicine in MECFS saying do X, Y, Z, and you just walked into a clinic, the first question is, what clinic should you walk into, right? Because you're going to get a different treatment depending on whose door you walk through. So it's kind of important, when you know all these different systems are whacked out, to walk through the door of someone who's looking at the whole thing, and not, I'm the endocrinologist and I'm the immunologist and I'm the cardiologist.
But you are an immunologist, but you do seem to approach this from a very holistic...
very integrative medicine. When I moved from my other university where I ran the immunology clinic, and that's what I saw was nothing but immunologic problems. And I came here, we re-envisioned the whole clinical thing to be, initially it was going to be multidisciplinary. So you can see an immunologist, a cardiologist, and all this at the same time. And then realized, actually no, because most of the cardiologists really don't know what to do with this, and neither do the neurologists or all these other specialists that see these folks. Who was doing the best job were people that were in integrative or functional medicine. Okay. So we ended up with 8 clinicians. I think we have 8 right now. And I'm the only one that's not bordered in integrative or functional medicine. I'm the sole subspecialist left. Although actually we have a hematologist in the group too. So, but she's also bordered in integrative medicine. She did smarter than me. I went back and took those board exams.
So that's quite interesting. It's not actually something that I have actually spoken, that term integrative medicine, which means combining, is that what you were calling it? It's combining like, specialties.
It is. It's so interesting because look at my gray hair. I trained in medicine before you triaged anybody anywhere. You just took care of them, I boarded in internal medicine and immunology. So the internal medicine training would have been, I got trained in cardiology, hematology, I got trained in all those things. And you only push someone off to a subspecialist if you were over your head,
Right.
But now it's like triage and just everybody gets consult with every kind of specialist. But for long COVID and for MECFS, it's a tough situation because somebody has to, even if you do that, who's taking all those consults and knitting it back into a management plan? Instead, you see people stepping on each other, prescribing drugs that shouldn't be put together because 2 different doctors ordered two different things or whatever. I just like integrative medicine conceptually because it's a whole body way of thinking. We do complex medical disease integrative medicine. Most integrative medicine is all about wellness, diet, nutrition, and do this and do that, and exercise. Something I'm very bad at myself. I should do more. True confession. But anyway, we do something differently because we're starting from people that are pretty darn sick and trying to help them, get up to better and better levels. So I think with our treatment style in our group, in other integrative medicine type folks, it's kind of a layered approach. Get them up a little notch and then get them up the next little notch until you bring someone out of the well into a much more functional space.
So that's a really interesting approach. So you're talking about just taking small steps.
Because people can't do big steps. I'm definitely far away from our COVID conversation about trying to find cures. But I'm trying to say someone who's been stuck for a long, long time in a chronic illness, there's not a magic wand that puts them better. Instead, you have to figure out the layers of their illness. What is autonomic? Can I fix that? Nutrition, it's amazing how many people don't have the energy to put a meal together. And you start looking at their nutrients. You're right, this person can never get better. She's not even feeding her mitochondria. So how is she going to make energy?
Yeah. And that goes back to what you were saying about all of the different time points, and you can't treat the person who's had something for 6 months.
Yeah,
the same
the early ones are
10
the
years.
easy ones.
What are the layers in that
but
one?
But
the
later ones are the harder ones, but treatable, very treatable, and respond to treatment. So that's where they're so discouraged because they haven't gotten effective treatment. They've been sick for a long time. Many times people are out on disability and feeling like their life is passing them by. And then you try to bring them back to the point where they're more functional. And then, interestingly, is when they are more functional, you got to be careful that they don't fly right back into making themselves sick. As I was on, actually, you mentioned Dr. Unger, and I was just on the phone with her, not right before this. And we were talking about cure rates. And I was remembering Kathy Rowe, R-O-W-E. She was an Australian pediatrician with the most amazing personal touch. And she saw every child that had ME/CFS in the south end of Australia. And then she followed them until they're well into their adulthood. So unlike just seeing them until they got to be 18 and passed them on, she kept up. And she surveyed her kids like in their 20s and early 30s to see what the recovery rate was. And the recovery rate was phenomenal. But when you really looked at it, it was adaptive behavior that made them feel completely normal and healthy. So even when they felt healthy, they were still being careful not to overexert. They were keeping their stress levels down. They were doing internal centered wellness kinds of daily activities, and they felt great. So, and so is that recovered? Or is that someone who's adapted to an illness to make it to the point where they're not currently symptomatic?
I think that's a really interesting question. I also wonder if, obviously, there is an illness and there's an adaptation that's gone on, but do you also have to look at whether the previous lifestyle of hard living, perhaps not sleeping enough, those kind of things were actually unsustainable in the first place? So perhaps the new lifestyle of pacing and nutrients is a more natural or an easier place for the body to find homeostasis.
But there's maybe a little bit of science to justify that hypothesis, because in ME/CFS, there are some papers that look at just, that type A, type whatever personalities. And there was more of what they call type A and type C, the cancer-prone personalities, that if you looked across the population versus people with ME/CFS, the pre-morbid, the pre-sick state was more hard driving or more keeping everything in.
Right.
Yeah.
I think it's interesting because perhaps this idea of the way you were living previously was not normal. This is the more normal way to live, this taking it slightly easier.
Yeah.
It's not necessarily that easy to come to terms with. So because I have that feeling now, I actually I'm 5 years, I've had long COVID, and my life, the way I live now is very different. I'm not able to live in the same way that I used to live. But for the past 2 months, I've been on a relatively even keel. with hugely adapted lifestyle
Well, that's
measures.
it, because, I mean, every Christmas we send out a newsletter that says, Happy Holidays, the following things you will not do. And we try to keep them from, because everyone, goes out shopping until they drop, and they fix their house up, and they try to cook for dozens of people. And even the relapse rate during the holiday season is extreme, very, very high. And I know what it is. It's just pure physical exhaustion on top of an illness that can't deal with that kind of trigger.
But having the illness, you're slightly able to go, I can't do this. So it exonerates you from...
But that takes you time, right? I bet you didn't do that in the first year. I bet you made yourself pretty much sicker than you would have otherwise been.
Yeah, very definitely.
Yeah. I wonder if there's culture to that. One time I was hanging out with some French doctors, and they said there was no such thing as chronic fatigue syndrome in their country. And I said, oh, that's just bullshit.
Really?
I mean, there's just no way. And he goes, no, there really won't be. Because if you got mono in our country and you were still sick after 6 weeks, we would send you to the medical retreat. It would be paid for by the you'd go
by the
to this
government.
Beautiful place on the river, and you'd walk in the woods and massage and stuff until you were better, and then you could come home. And I'm like, well, I wonder if that's really true. I don't know the French, way of practicing medicine, but what a lovely way to practice medicine.
Yeah.
I hope it's true. I hope they don't have it. I think they just don't recognize it. But pretty cool answer. I thought that was neat.
Yeah. You've recently been part of quite a few papers, the comorbid pain condition papers with the CDC, where you've looked at...
Nice to see. Yeah.
Yeah, where you've looked at back pain, migraine, various other conditions that are comorbid. You've done a study looking at joint pain. That's in long COVID, a study looking at cognitive dysfunction in ME/CFS. In terms of your research, where in our bodies or what is being affected and impacted, all of those things, are they coming together in some kind of cohesive... Are we now understanding with all of these disparate symptoms or disparate parts of the illnesses? Is something becoming clearer in terms of them coming together?
Yes.
I mean, just in the research that we've been doing in the last 5 years,
yes,
is it getting...
Definitely. I mean, I'm going to say the work we did the first 30 years was also telling us these things and no one listened. So it's not
interesting
like it's
point.
new.
Yeah, very interesting point.
When I was in the Institute of Medicine panel for ME/CFS's case definition, and they were doing this intense review of every paper ever written on ME/CFS, very critically, very evidence-based, very carefully done the way they do at the National Academy of Science. It's really an amazing process to be a part of. But they were dismissing so much of the stuff in our field, almost offhand, not because it wasn't important, but because it was never validated. That you would do the first study with 30 or 40 people and you make the observation, and there was no one to pass the torch to validate that. We're such a small field. There's, 100 of us maybe in the whole, 150 maybe, in the whole field doing science. And when you try to get funded to do validation, it's not original. You don't get funded for that, right?
Right.
So what's cool about this long COVID study, the recovery one, even though I'm not in it, I can be really pleased with having 15,000 people, because they can look into 5,000 and then they can go find a different 5,000 and validate their own work with a different chunk of the cohort, right? And it's like, kick ass, indisputable, you proved it, no one's going to argue with you. That's evidence, right? So we've never had a sample size close to this long COVID sample size that they have there in some other countries. The other thing they're doing, which is amazing, is with AI, data digging through medical records, right?
Yeah.
Which used to be pretty crummy because you had to do word recognition, text recognition, try to figure out what that means and build in some programming to try to make sense out of that. But now it's just AI is much cleverer. It actually could read almost contextually the way I read. It's very close to being able to pull out of text really meaningful phrases. So they're able to do more than simply search for codes and look at numbers. They actually can look at recovery rates and look at what medications people are on that influenced what. So
yeah, that's amazing, isn't it? Because in that sense, you can pull out data that you almost didn't know that you were looking for.
Exactly. Yeah. I mean, you've seen the VA does this now. It's the system called Vinci. I forget what it stands for. Anyway, they have more than, I don't know, crazy number of veterans. I think 40 million veterans in the healthcare system.
Wow.
So you can look at 40 million medical records for codes or buzzwords or something. It's pretty cool.
Yeah.
And then they've been publishing one paper after another that was really important. Early in the pandemic, they were publishing the rapid release important observations from clinical interventions and changed the way we were treating acute COVID. That was pretty cool. And it's because they could do it with a computer, just doing, yeah, really cool. Some cool stuff. So having these new tools, and those are, like I say, big N studies. When you look at 40 million records, no one's going to argue they couldn't find something. So it's pretty neat. And those things find stuff. So there's study, and again, I'll use France as an example just because I remember this one. They did one of those big reviews before COVID for risk factors for Parkinson's disease. So it's a disease I'm very interested in studying. They discovered that people with asthma had a lower risk for Parkinson's disease. Well, that didn't click, but there was a definite association. So then you could dig back in a little deeper and you could discover that the puffer you take for asthma, which is essentially adrenaline, was neuroprotective. And these people that were on asthma meds for many years had been taking, unbeknownst to them, a neuroprotective agent in their puffer. Well, it kind of changed the way we thought about the whole brain thing, right? Because we didn't know that should be neuroprotective. Someone had to postulate, why would this asthma do that? Yeah. Shouldn't, it's inflammatory, it should make everything worse. But I'm taking puffers. And they have, one of them's got adrenaline type things in them and the other's got steroid type things in them. What would that do? And that started making some sense. It was kind of cool. So that's digging into a massive data set, looking at the entire population of France, literally, because it's a healthcare system, and then finding these patterns that actually help you discover the biology of an illness that you didn't know. Kind of cool.
So that's what our technology is really stepping forward. And AI, that is one of the positive developments coming out
AI
of the
is not
AI.
all positive, but that is positive. Used appropriately and understanding what its limits are.
Yeah, I was actually saying this to someone the other day, that there are amazing things within the medical field that can be achieved with AI, the advancement.
It's pretty cool.
So in terms of MECFS, you were part of the directive in 2017 with your whole crew. These people who have been working in MECFS for decades. The names that come up on all of you all seem to work together.
And mess with us because you can't review a paper if you've been on a paper with somebody else in the last 5 years. You can't review the grant. And there's about 5 years there where none of us were available.
Not allowed.
There was no expert left in the country because we were all on the expert panel.
So you were part of the team that created this standardization of how you evaluate and treat MECFS. Yeah. And now in 2025, you're actually, I think, are you doing another project? I don't know if you'd call it a study that looks at the clinical assessment and.
I think you're talking about our CDC study, the COVID up study. Is that what you said?
It was about MECFS and the clinical assessment and creating a biorepository.
Yes, that's exactly right.
Is that in MECFS or is that in long COVID?
That one's long COVID.
Oh, is it?
But it's being compared to the MECFS one. So right before the pandemic, we just finished a 5-year study of MECFS with the CDC designed the study, contracted 7 sites to recruit.
Yeah.
So there were 7 sites with the who's who of.
Yeah, that was a sort of longitudinal study.
It was a longitudinal study. It was very comprehensive. It was a kind of a deep phenotyping study. It had lots and lots of components to it and a lot of assessment. And it's pre-pandemic, clean pre-pandemic cohort of MECFS. So the problem post-pandemic is we don't pick out the MECFSs that aren't long COVID.
Yeah.
Because how do you know? It's getting trickier. So that's the comparator group, is this nice 750 patients that were in that study. And now in this study, the long COVID study, we repeated essentially the same assessment with a few more biomarkers that weren't available then. And we are digging into the biorepository from that old study.
Right.
To be able to do comparisons with MECFS. So it's a very exciting study. We're just sending samples off to the Olink assessment, which is a big proteome link assessment at Vanderbilt for both those cohorts.
And is the hope with that you create that slightly more standardization in terms of long COVID, or is it just to develop your understanding at large in terms of ME/CFS and long COVID?
Quite deliberately, we're comparing the two to see where they're the same and where they're different. Okay, with a large enough group to be understanding gender differences and whatnot. We're particularly pleased with it's called COVID Up, the COVID Understanding the Post-Viral Phase, COVID Up. And we're in the final year. We have about 900 people in a longitudinal sample, and we're bringing in 200. We've got 150 complete-ish, maybe a little more, to bring them in for the deep phenotyping part and have all the samples and things, and then batching those up and sending them off to the best labs in the country, like Dr. Ware's lab at Harvard's going to do the spike protein assay for us, for instance. And the O-Link thing's going, and then our own laboratory here, which is doing cytokines and hormones.
And that's very exciting. That can sort of sit alongside the study that I spoke to Suzanne Vernon about, which was looking at the prevalence of ME/CFS, which was actually done based on the data of self-reported symptoms and how people were feeling. And you're suggesting here that what you're doing is you're taking samples and you're doing assays to actually look at...
In addition to all that self-reporting. The poor patients are doing, a couple hours worth of self-reporting every time we assess them. So they're really being very generous with their time and their dedication to this study. And I'm grateful. And the MCAM study, the original CDC study, was also equally time-consuming for the patients. Yeah. And so, but anyway, they're great studies to try to answer that question, where are they the same, where are they different? What's nice about the one that we're doing now for long COVID is that it's here in South Florida. We're doing this great CDC study and an incredibly diverse community, which is South Florida, where we're just a tremendously diverse community. And we recruited this study using hospital systems so that we send out emails and links to everybody in the whole hospital system, begging them to be in our study. So what we ended up with is a demographically representative cohort that very much looks like South Florida. 55% Hispanic, 19% African American, which is a little bit different than the MCAM study because that was a clinic-based. And you will always find, particularly in expert clinics, that you have to have advocates and resources to get into expert clinics. They're just overwhelmed and too many patients to see, and somehow those most diligent people get in. So I look at this group that we have coming in from the county hospitals and things, and I'm so happy to see them getting in a proper assessment. And the data that we're learning from is truly the data that's in our community, and not just the people that can find
fit
us.
a certain demographic. Yeah. Amazing.
Yeah, it's good. Are you talking to Dr. Theoharides?
I spoke to him already.
He's great. He's our most popular podcast. He gets the most downloads of anybody. He really does.
So lovely.
He's great, but he has all these connections. The dysautonomia community knows him. The mast cell activation.
But this is what's so interesting about so many of these crossovers is that people were put into boxes, but they're actually...
And they're not. He's a great guy. I love his career because he's a doctor who saw something, pursued it, had his own laboratory, gave us most of what we understand about mast cells coming out of his laboratory and his career trajectory, developed interventions that treat those abnormalities, and then saw them all the way to market. Good for him.
Yeah.
It's so many people that do science. They do these amazing discoveries. I mean, I've had PhDs that were retiring come and hand me boxes of stuff and say, please take this and move it to the next milestone, right? I'm like, oh man, how awful it would feel if you were retiring knowing that you hadn't taken your discoveries all the way through to patient care. And that's our privilege as a group, is that we have this amazing group that can take a discovery and get it all the way through.
And get it to patients.
Yeah, exciting.
Yeah. It's very exciting. Yeah. Is there another study that you would like to talk about?
We're doing the reboot study, which is trying to reboot systems. And that one's had a long stall for the pandemic. We were about to do it right before the pandemic, and we got stalled because some of the medications are immunosuppressive and you can't use them during a
a pandemic.
So it took us a while to get that one rolling back again, but now that's finally off the ground. And we have a study on the microbiome using probiotic types of treatments to try to get a less inflammatory.
Because those are the kind of things that you actually advocate for, aren't they? Using simple things, yes. Probiotics.
Using food as a therapy, it's really important. And if you looked at the diet of people who are too ill to stand in the kitchen, you'd be shocked what they're eating. They're just
not getting the nutrients.
They're not getting the nutrients. They can't get better if they don't get the nutrients. But also nutrients are anti-inflammatory. They're things to know about your diet that can help your immune system recover. And that's really important.
So if there was one thing that I asked you for people with chronic illness to consider or just to think about, if there was one piece of advice that you could give them, would that be, would that be nutrition today, or would that be?
That's a thing, but I say it's a layered approach and they're all important. Restorative sleep, how important is that? It's not an easy thing to achieve, but that's when you heal, that's when you mend. There's actually a flow of something called lymphatics in your brain that reverses its direction when you're asleep and detoxifies your brain. You need sleep to detoxify your brain. That's terribly important. You wouldn't even think these two things are connected, but boy, are they connected, so anti-inflammatory foods and nutritious foods, never putting anything in your mouth that's not going to actually help your body. That makes good sense. And you get restorative sleep and have a family that loves and supports you. Keep your networks together and love them back for it and support them. Be a part of the love circle. It's really important. There's so many parts to this. What do you say? And then, the immunologist says, take good care of your T cells. But that's, trickier. And yes, your microbiome matters because it really messes up your whole body if it's wrong. That matters. Yeah, that's true.
I've had a whole hour with an immunologist and we haven't talked about the T cells, have we?
It's okay. That's for another talk.
That's for another time. And in terms of this going forwards, outside of what your team is doing here, which is incredibly exciting, and talking to Dr. Theoharides as well, it just seems that you are all so involved in interesting areas. Who is doing exciting work, or what is exciting outside of the work that you're specifically involved in? Because every time we talk, you mention so many people.
But there are so many good people. That would be hard to say.
About this network, about the way that you all collaborate. It's absolutely amazing. And it's not just within your country, the collaborations that you seem to have outside as well.
Yeah, no, it's got to be international. In fact, I love, if you look at our group, our clinician group, we have someone who's born in Russia, someone who's born in Poland, someone who's born in Israel, someone who's born, everyone's from somewhere else, right? And when you talk, and they learn medicine there. So when they come to me with my U.S., not just Western, but U.S. Western medicine, and I realize, man, am I in a little box? These guys know things I've never heard of. And so I long ago committed to go to international conferences and learning from everybody because they bring so much to the table. And I've learned a lot that way. It's really helped us and helped us develop our ideas and our thoughts.
I continue to be blown away by the people operating in this field. The level of dedication from people like Dr. Klimas and her entire team there. And I have to tell you that the facility at the Institute for Neuro-Immune Medicine is phenomenal. The people that I met were so dedicated to rigorous, robust science and compassionate care. And as Dr. Theoharides said in episode 13, they are truly thinking outside the box and look at these conditions in a multifaceted way. I feel that people are in safe, progressive hands under their care. I am genuinely humbled by the people that I meet working in this field. So whilst I wouldn't wish chronic illness on anyone, I am so grateful for the path that my life has taken that enables me to have these conversations. thank you to each and every one of you who contribute to this research, to this care, and to making progress for patients and our medical understanding at large. Thank you for listening to Make Visible. Please do like, follow, or subscribe to listen to our next episode, where we'll be uncovering more insights into complex chronic illness. This was brought to you by the team at Visible, a group of scientists and engineers whose lives have been affected by energy-limiting health conditions. We're building wearable technology that's helping 100,000 people measure and manage their complex chronic illness. To find out more about what we're working on and how Visible could help you, visit our website at makevisible.com.